to join us, which shows such dedication to this ML4 meeting that is above and beyond. So I want to introduce you to Brian Wishart. Very few of you have had the opportunity to actually meet Brian in person, which is actually super unfortunate for you, because Brian is an extraordinary addition to our team and much, much needed. So Brian works in the field of rehabilitative medicine, which many of you depend on in your own communities. And when Brian joined the community at Massachusetts General Hospital, Brian was immediately snapped up by pretty much every single person who has sort of wanted a piece of him because of how valuable his knowledge is in helping people who deal with chronic conditions like ML4. As Albert said when he was giving recommendations of care in the latter part of his talk, you know, many of the issues that he was responding to in terms of recommendations of care were not particular necessarily to ML4. And I think in many ways, some of the things that Brian will be speaking to reflect that. But many of the things that cause your children ongoing concern, perhaps pain and discomfort, are conditions because of the chronic nature of the disease. And so I really have been really impressed with how creative and knowledgeable Brian is about so many of the issues that really impact your kids' daily living. And so I give Brian now to his presentation and thank him for the commitment that he's given to thinking carefully about our kids. Thank you, Brian. Brian, you're muted.
All right, thank you. Can you see my slides?
Yep.
Okay, so thanks everybody for having me. It's been a pleasure to meet the community and see everything that's been going on, and I really appreciate the opportunity from Rebecca and Dr. Misko and Dr. Goschuk to help with all of this. So what I'd like to talk about today will definitely have some overlap with Dr. Misko's talk, and we'll just kind of fine tune some of the points and talk about what options are out there and overall in a few little spots. So just briefly, just because it's a small community, the pediatric physiatry group, I just want to talk a little bit about what we do. You know, it's primarily taking care of children with disabilities and sort of the functional aspects of what that means. So whether that's tone or bracing, equipment, therapy plans, all of those things sort of fall into the purview of what we address when we see patients, and that often leads to fairly long visits. But I think one of the important aspects of it is that most of it is management. So we're not necessarily just treating something. We're not coming in and saying, oh, I'm tight, and that's it. We're going to move forward and say, okay, this medication will make you less tight. But really, what are the goals of care? What are the things that we're looking for out of our lives and our function and what we're able to do, and how each one of those symptoms that we're discussing is affecting those, and what we can do to kind of make that patient or that child more functional in their day-to-day lives. So there's a wide range of what we take care of. If you look at the adult side of physiatry, there's specialists in spinal cord injury, traumatic brain injury, more of the neurologic aspect. Pediatric physiatry often encompasses more of this, though we do somewhat specialize. So I have taken an interest in more progressive neurologic disorders. I work in several of the other neurology clinics, including leukodystrophies and other things like that. So that's sort of how I landed here. So just an overview. We'll talk a little bit about spasticity and hypertonicity. I was going to go over a little bit of the definitions. I think we'll kind of skip over that since this has been long, and Dr. Misko did a great job explaining some of those, and we'll just jump into sort of the treatment strategies for that. Then we'll go over scoliosis and some of the characteristics associated with neuromuscular scoliosis. We're briefly going to touch base on some of the mobility challenges and what we can do to help that, because bracing on its own and equipment can be hour-and-a-half long talks individually. And then again, we'll briefly touch on adaptive sports just from some of the questions that came out of the pre-conference. So for spasticity and hypertonicity, you know, we talked a little bit about what the definitions are. It's really what kind of our resting tone is. And hypertonia is sort of that overarching view of what we're seeing often. So we do see some central hypotonia from what I've read and talked with Dr. Misko and some of the patients, but really it's that hypertonicity and whether that's spasticity or dystonia, which you guys heard about. And then sort of the range of both of those can
Brian,
potentially
I
be
don't see your
studied.
slides anymore.
Oh, no?
Is it just me?
I see them. It's Diana Bensol. I see the slides.
Sorry to interrupt. It must just be me.
I see the slides.
Okay. My apologies, everyone. Keep going, Brian. I'll sort it out.
You know, I think the big thing that when I look at tone management is really that it's tone management, right? And so spasticity is there, hypertonicity is there, and often it's not necessarily all bad. Some of this is used for transfers, for ambulation, for keeping some sort of ability to transfer that patient and pick them up, right? If they were completely flaccid and hypertonic, most of these things would become very challenging. And so our goal is to figure out where that balance is of how much tone we need to get rid of, what the bad parts of it are, and what we're trying to achieve with this. And so typically when we look at the options, there's sometimes described as the gradient, where we start with stretching, therapy, bracing, then there's oral medications and focal tone management with injections, and then there's more of the surgical procedures. And as we're going through this more, I think our reality is that this is not necessarily a stepwise manner, and that we should be looking at this more of that circle on the right of how do we incorporate each one of these into a full therapy plan, tone management plan that will get us the best results with the least amount of side effects. And so physical therapy, occupational therapy, other therapies like hippotherapy or aquatherapy all have huge roles in maintenance of keeping our children functional, keeping that tone down. And we're seeing a lot of it right now as kids are not getting that therapy for 2 months. A lot of their tone is getting worse, and functionally they're getting worse. Bracing also plays a big role in this. So nighttime bracing is able to keep us into kind of a neutral position and give us those prolonged stretches where you can imagine if we're stretching, even if we did the most we could imagine, and it's 20 minutes, 3 times a day, 4 times a day, that's still nothing compared to if we're able to put a brace on overnight and wear it for 8 hours, or a knee immobilizer and keep that knee straight for, 4 to 6 to 8 hours overnight. So that's usually our backbone. That's where we kind of base our therapy, and that's going to be our maintenance for maintaining these things. On top of that, we have multiple options for oral medications, and Dr. Misko went through a number of them. There's kind of a small list in that bottom right of that circle there. But baclofen is often a baseline, a first-line drug for us. I think you need to think about when children are getting tight, how they're using that tone, and what kind of side effects and what other things are going on before you start, as you start to choose these. If you're able to use one medication that may help with multiple things, that's always a good option. So dystonia is a big part of this. Sometimes our clonidine or tizanidine, the alpha-2 agonist, can be helpful for that. Sinemet is classically a dystonia medication. There are some institutions that are doing some research to see if it does help with spasticity as well. And so I think individual disease processes, and as we go through this natural history study, looking at what medications are having success is going to be really important, because the reality is a lot of these diseases do respond differently to different medications. And we see that. Botox, I think, is used a lot across the board, and it's often helpful for spasticity. It's also one of the first-line drugs for dystonia. But we do see in certain neurologic disorders that patients end up having a much more significant response to it. So underlying spasticity, often due to disuse, or if there's another mechanism that we're not necessarily clear on, there's weakness. And so when we start taking away this tone and this spasticity, you're going to see less strength come out. And so some patients we've seen in different disorders, as you treat, if you use the same amount of Botox you would use in a traumatic brain injury patient, you see a lot more weakness in that. And that's something to keep an eye on as we go through this and keep track of how patients are responding to each medication. There are surgical options out there. So intrathecal baclofen pumps are a wonderful option. I'm a big fan of them. Where I trained, they had a huge baclofen pump program. One of the challenges is with tone management is often it's cultural. So certain institutions use a lot of pumps. Other institutions use a lot of dorsal rhizotomies. Other institutions use a lot of focal tones management with Botox. And so trying to find the right option for your child in particular can sometimes not necessarily be as clear as possible because it may be related to how that physician trained and what's going on. But I don't think you have to go through and say, okay, we failed Botox, now we'll think about a baclofen pump. Sometimes that baclofen pump may be a great first line option. And we've seen a few patients in this area that have, with progressive neurologic disorders, that have jumped to baclofen pumps and had really nice results. The benefits of that are that you're not giving it orally, so it's not going through the system. You kind of skip the liver and you're not getting those side effects. You also have somewhat decreased sedation. There are some side effects with constipation and sometimes urinary retention, but are often manageable with other medications. So these are good options. And I do sometimes talk with families earlier on about trying to move this as opposed to taking, tons and tons of oral medication or having them come in for Botox injections every 3 months, especially if they're requiring sedation and other things that put them at risk. So one of the things that when I think through our tone, I think about it more this way, where in each aspect of this circle, how much of which one are we using? So are they kind of earlier on in their disease process where we're really basing this off of physical therapy and bracing and stretching? We're using our seating position and other adaptive options with maybe some oral medications to maintain that tone, or is it something a little bit different where they've had a baclofen pump placed in and we're able to wean off a lot of oral medications and using more of that intrathecal delivery for it? It's very individualized to patients, and this is something that I think needs to be worked through with a physician and not just kind of, okay, we have tone, let's do everything we can to treat it, but what are our goals as we're going through this? I'm going to try to be a little bit briefer. There are orthopedic options. Most of the ones that when we talk about with tone management, it's those tendon lengthenings. Again, there are things that are permanent, similar to the dorsal rhizotomy, which we didn't really talk about, and I don't know if it really applies necessarily to this group. But these are things that I think you need to be thoughtful of because there's not necessarily a weaning back. If we treat and we find that we've gotten too much range out of a certain muscle, that's where we are at that point. We're going to be relying on bracing and that sort to fix it. So I'm a little bit slower to recommend some of those more permanent methods in our progressive patients. So moving forward, we're just going to talk a little bit about scoliosis here. Neuromuscular scoliosis is a very challenging topic. Across the board, it's hard to treat, it's hard to maintain, and it really has a big impact on a lot of patients' lives and how they're moving forward and their function. It's incredibly common in our neuromuscular patients. Papers report anywhere from 90% to 100 of patients will experience some level of scoliosis, and typically are spastic patterns. So kids with tight muscles in that truncal region as well as elsewhere are more likely to progress and have more severe symptoms as they progress into older age. Some of the important differences from idiopathic scoliosis, which is what's talked about more frequently, and this is kind of our classically, 14, 15-year-old females that get some scoliosis and may need a brace, may not. In a neuromuscular scoliosis, it can be much more involving. So it can come all the way from the pelvis and the hips and have some obliquity there and cause a curve all the way up and around through potentially into the cervical spine, but often into the lumbar spine as well as the thoracic spine, all the way up into the chest. It progresses at a variable rate. So it can be early on, you can see children progressing fairly rapidly, but you also continue to progress past skeletal maturity. And I think that for me is one of the hardest parts, is that there's not necessarily a good endpoint. In idiopathic scoliosis, if we're able to get those patients, past 14, 15, 16, when they start to fuse, they're not going to progress anymore. Which is not the case in neuromuscular scoliosis. You do see ongoing progression as that muscle disease, as that spasticity and the movement disorders worsen. And so it does present a different challenge when we start talking about it. The deformity can often be very impressive, and it often scares a lot of people when you see these patients. This is, as treated, it looks pretty good. You saw some of the previous pictures where it really is pretty dramatic. And one of the challenges when we start talking about treatment is that there's often other things going on. And so whether that's nutritional deficits that will make surgery a challenge and recovery and healing a challenge, if there's issues with their lungs and breathing, cardiomyopathies, renal disorder, anemias. There's other things that can be caused by the scoliosis from constipation and other bladder concerns. All of these come into whether or not we should be moving forward and how we should be moving forward with treatment. And so for our treatment, there's a lot of options to some extent. I think our first option is really observation, right? So if we're early on, there's not a big curve. Really what we're going to do is we're going to watch and we're going to see if this is progressing. We're going to see how quickly this is progressing and see what quality of life issues and other degree, what other needs are being affected and function is being affected. Bracing is an option for these patients. The problem with it is that in order to be successful with bracing in terms of preventing progression of this curve is that they need to be wearing that brace for an extended period of time. And often that can mean up to 22 to 23 hours a day. And the reality is that is not something that happens. Sometimes patients will try it, they'll start working on it, and they're able to make it a year or 2 years where they're wearing it that frequently, but it just gets in the way of so many other things that they cut it back. And once you start cutting back past about 16 hours, the likelihood of preventing that progression is very low. And the other side is there's certain studies in neuromuscular scoliosis that show even if you are wearing it a lot, it may not necessarily prevent that progression. And so, excuse me, we use the TLSO for other reasons in these patients. Often it's comfort, often it's sitting position, often it's functional ability to use their hands, to be up, to help with their swallowing, to be upstanding, to help with weakness and other options there, but it may not be something that we're using really for treatment of the scoliosis. So our last option is really our surgical interventions, and these are rods being placed. The rods have gotten better, the surgical approaches have gotten better, but it still is a major surgery. And when to go into this is, I think, a big discussion and a challenging discussion for a lot of patients. And I've had this multiple times. Where early on, we talk about surgery a little bit earlier in neuromuscular scoliosis. In idiopathic, they won't talk about it until about 45, 50 degrees. In neuromuscular scoliosis, we'll talk about it earlier at about 35 degrees. And the reason for that is that rapid progression. So if we see a patient at 35 degrees, they could quickly move to 45, 50 degrees in no time. Excuse me. But the other hard part is that there's other things going on with respiratory status, nutritional deficits, and as these patients progress in their scoliosis, often their disease is progressing as well. And so what we end up seeing often is early on, the scoliosis is maybe not as severe enough to warrant surgery, but then we rapidly kind of progress past that point where surgery is safe and easy to where surgery is needed, but the patient may not be able to tolerate it well. And this is a challenging point for families because they feel like they should have done more early on. And that's not necessarily the case. It's often kind of a lose-lose where you've done everything you should have. You've had them in braces, you've been monitoring closely, and everything is kind of coalesced to the point where it's a challenging decision to make and discussion to have. There's certain places that will proceed with that surgery, and it can be helpful. And we've seen patients go into halos where they have a brace around their head and they pull them up for a few months or a few weeks to give them some elongation and help with that scoliosis, and then move to the surgery. And I will say that we have variable success. I've seen patients do wonderfully with this. I've also seen where we've decided not to do the surgery, and that's just, we've managed it with positioning in the chair, with bracing as tolerated, and we move forward. So it is a very individualized discussion, and you have to kind of figure out where you are in terms of quality of life, what the patient's needs are, what our expectations are moving forward, and what our risks are with that surgery, and make a decision as a team. So I will say I was on the call with a respiratory pulmonologist, an orthopedic doctor, myself, and a complex pediatrician for a patient with a different progressive disease not too long ago discussing this. And it's always a challenging discussion. So having a good team behind you, I think, is the most important thing you can do when it comes to the scoliosis aspect. In terms of our mobility, there's lots of options and lots of challenges that are out there. Bracing can look like a lot of different things. It comes in a lot of different forms, from You know, these very small braces at the top where we see these just kind of almost inserts that have a little bit of support around the ankle, and may help with our foot positioning and some of our step mechanics. And some of these, like this small one here, are UCBL, that really give kind of a hard support of the posterior aspect of our foot versus more supportive, you know, shoe inserts. These are chipmunks, that can help with our foot positioning and plantar aspect. And then you can move up in terms of, you know, bigger aspects, our SMOs, which come up above the ankle bones and really help with that medial lateral stability. And if our children are falling off and potentially rolling their ankles, AFOs can do all of that, as well as help with some of our stepping. So if we're toe walking, or we have a foot drop, or we have challenges with tone in that aspect, these are good options. There's a couple different variations you can see on the bottom left here. This is kind of what we call a ground reaction force one, made out of carbon fiber versus our plastic ones. Bracing is a really challenging thing to give an overview of because it is very individualized. So our brace clinics are composed of myself, a physical therapist, and an orthotist that make the brace. You know, we watch gait. If there's challenges, you can do gait studies. If you're not sure exactly what's going on and which muscles are firing to cause this. But I think they can be very helpful. There's often I think going into it with your goals is important, as with everything. My goals typically are to help with stability, right? So we want to make sure our patients are safe, that as they're going through that, you know, they can stand, they can feel like they're capable of standing. And often we see patients be a little bit more functional as we give them that stability, even if we're taking away other aspects of motion. Increased efficiency is another big aspect of this. When we talk about gait, every part of everything we do with gait, from as we're learning it, has to do with efficiency. We want to use the least amount of energy to move the furthest, and that's our goal as our body. And if we're able to help with that and increase efficiency, even the smallest amount, often that will allow our patients to use less oxygen, to use less effort and muscle strength when they're walking, and give them kind of the ability to go further and do more. If there's weak muscles, that's another option that we have. One of the kind of impressive and amazing things about AFOs is we're able to, from bracing that ankle, really control the knee and up. And so we're able to make changes to the entire gait mechanics of the lower extremity, often with just supporting that ankle. And so you can imagine when we put that down, once our foot's down, we're actually controlling how the shin moves versus just how that ankle moves when we're not down on the ground. And so that gives us that control over the knee. And so weakness, even up into our thighs and our hamstrings, can often be treated with AFOs without having to go to bigger braces, which I didn't really talk about here, in terms of ones that brace up to the knee or potentially up to the hip. So I think going into our bracing discussions with what our goals are and how each one of these things is going to affect those goals is the most important thing when we're having these evaluations. So if you see, oh, you know, he's not doing as much as he was, or she's having trouble standing and being safe, those are the discussions to have as we're going through. And then, you know, improving alignment. And sometimes that means just those inserts, which will help, you know, with flat feet, we can get them back up, potentially straighten out the knees at some point. But it also may mean these nighttime resting splints, where we're giving them that long-term stretch overnight and then allowing them to sometimes have less bracing during the day, or just increase function during the day from having a better stretch overnight. Equipment-wise is another large topic that I wanted to touch on briefly. You know, there's discussions about what is the most effective, what should we be moving to, and what should we be using at what times in a child's life. And my role and my discussion with families when we're going through bracing as well as equipment is really we should be using these to increase their function, right? So if they are having physical gross motor delays, but they're able to socially, and they're increasing their social awareness and fine motor and that sort, those are the times that we want to potentially accommodate for deficits in the gross motor area. We want to let them learn as much as they can, but we also want to make sure that we're not having a deficit in one domain affect or potentially worsen a deficit in another domain. And so these these seating options, like the Riften activity chair you can see in the top right, there's another one called the tomato chair. These give children the ability to sit up when they may not have that control of their trunk, and not put so much effort into trying to control the trunk that they tighten up everywhere else. And you see that when babies are young and they start lifting their head up on tubby time, their hands will clench up and they get very tight. And you see that as kids get older as well. If they have trouble maintaining that trunk control, when they're working really hard to maintain that trunk control, it's going to worsen their fine motor function. The standard, I think, is another option for that as well. We see kids do really well when they're able to get supported and be upstanding. And this helps with their social development too, right? As kids get older, they want to start being upright. At 6 months, they're sitting. At a year, they start standing. And that's something that developmentally they want to be doing for more reasons, just for walking and trunk control, but also that social development. There's also some medical aspects to the standard. It helps with bone health. It helps with constipation. It helps with our stretching and our tone management as well. You can imagine in a standing position, we're getting all of the weight of gravity pushing down on our ankle dorsiflexors to help stretch out those ankles. We're stretching out those knees and helping with the hamstring tone. So these are things that should get incorporated in a developmentally appropriate time. There's other things that are there more for safety and convenience, if you will. So bath chairs are a big safety aspect of this. We want to make sure kids are safe and have a good stable position to make sure they're getting cleaned in. Commodes can be an option instead of trying to transfer into the bathroom, being able to do that somewhere in a more safe and controlled manner. Medical car seats are something that come up with certain patients. Often we have children when they're small enough in just the standard car seats, but at some point they're going to grow out of those. And if they don't have that head control, if they don't have the trunk control, they're going to need to maintain some sort of supported seating aspect. And again, this is all somewhat individualized. There's options that range from just, different straps that connect to the regular seatbelt that make almost a 5-point harness for kids. And we've seen children do really well with that, to making sure you have a neck roll in to maintain the head control and see that you're not having too much kind of whipping or anything like that as you go through. And then wheelchairs are a big option, or a big discussion as well. And how functional the child is and where they are in their development, I think, is important. They take a long time to obtain, right? So as we're going through, we need to almost be looking 6 months ahead. And that's something that I think is different for a lot of physical therapists and equipment clinics when we start talking about our progressive children, where we may typically see them cerebral palsy,
I'm losing the doctor's audio.
Brian, I think you're frozen right now.
Oh, okay. Thank you.
Yeah, I think. Is that better? Am I back?
Yes, you're back now.
There's too many people in my house. I had prioritized my computer on our Wi-Fi for 2 hours and it had ran out. So wheelchairs, I was just talking about, with progressive diseases, having a natural history of what we expect and how important that natural history study is going to be there, but also talking with your equipment clinic and your physical therapist and the team that's prescribing these, and discussing what the needs of the patient are right now and what they could potentially be, and making sure that those chairs grow with that child, and that you're not having to readjust these you may have to readjust them, but reorder them every couple months because you hoped that things would potentially be getting better, or that we were planning for where we are exactly right now and didn't give us any room to grow, are always important when you're having those discussions. All right, and then finally, adaptive sports. I'm a big proponent of adaptive sports. I think there's a huge amount of benefits for it, for really all children. And I've seen some of my most severe cerebral palsy patients, GMFCS 5, that are minimally communicative, really gain a lot of joy with the family and everything, from adaptive sports to kids that are pretty functional, GMFCS 2, that are some deficits here and there, that sometimes play in the regular sports that are not adapted at all, but also there's a big benefit to being able to play with your peers and feel like you're excelling as well. So there's some just definitions that we have out here. So adaptive sports are sports that have been adapted from able bodies. So whether that's wheelchair basketball or soccer, there's lots of different options out there. For our younger kids, I think adapted play is also a really important aspect that doesn't necessarily get a huge discussion. It's a little bit small, but this right here is actually the playground out front of Spalding, and this is a fully adapted playground that has swings for wheelchairs. Everything is inclines and not necessarily stairs. And the community comes there, and there's kids that don't have disabilities that are playing there, as well as our inpatient unit gets privileges to go out and play in that at all times. And it's a great place for everybody to kind of come together and play together. Paralympic sports. So this is sports in parallel. There's often a discussion there. People ask if that's because of paraplegia, but it's really the Olympic Games that were built in parallel to the regular Olympics. And these are often, typical sports that are adapted in some manner for some sort of physical deficits. And then there's the Special Olympics that are year round, and these are athletic competitions as well as training, and typically for children and adults with some level of intellectual disability. There's been some research out there to see what benefits and whether this is really worthwhile, and the reality is almost across the board is it finds that there's a pretty big benefit for this. Most children that end up doing this, or athletes that do this, describe an improved sports skill, which seems like an obvious thing. If you do it more, obviously you will get better at it. So not a big surprise there, but you also see increased levels of self-esteem, self-worth. They get more social interaction with the other participants as well as non-participants within the group. The families reported a lot of benefit as well. So 70% of parents reported increased family time and finding things that we're able to do as a group family in a unit that wasn't necessarily just taking care of that child and feeling like, they were not doing something fun, but something that the other siblings were able to participate, and they were able to interact with that child on a more normal, if you will, basis that was described as fun for a lot of these patients. So most of these families, 82% you can see reported a positive effect on the family life in general. And yeah, so again, a more normative experience with their siblings and others without the intellectual disability. And so this comes from the Special Olympics, but fitness, joy, and courage, sharing of gifts, skills, and friendships, I think is a nice way of describing it. And then finally, some of the things to talk about: how do we get there, and what's some of the hard parts of getting our children involved in these sports? Some of the barriers that have been described in the literature, there's just decreased activity compared to age-matched peers across the board. It's harder to get out, it's more effort, you have to really kind of make the plan to get there. They've also found that there's a lack of diversity in sports, right? Most children's sports are group activities. They play soccer, they play t-ball. Really, it's more of a social interaction than a sporting interaction for these children. Versus when you look at adaptive sports, there's adapted bikes, there's adapted skiing. It's a lot more adult-based activities, and it's more individualized activities, and you lose some of that social aspect. So I think trying to find areas where you can do those adapted play, or if you're able to find adaptive basketball or anything, even dance class, there's a couple programs around where I practice that the Boston Ballet has built these dance classes for children. And those are the types of things for especially young children where they're getting that social interaction that I think is so important. Some of the facilitators, if you understand, families that understand the health benefits of physical activity can be a big motivator for getting out there. Families that do it themselves and believe that physical activity is fun, right? That's a big motivator and gets children out earlier. And then just having access. And sometimes this can be a real challenge. I have actually found that social media has been a big proponent of connecting people and showing them what's available out there. So if you're able to find somebody online that you enjoy, just kind of going through that rabbit hole and seeing who's following them, who's local to you, who they're liking, what they're commenting on, can often give you that broad perspective of what other options are out there. And so we've tried to kind of just run through that and put together resources of locally, statewide, nationally, what's out there and what's available. And this is the motto from the Special Olympics of "Let me win, but if I cannot win, let me be brave in my attempt." I think that's an important way of going through things. So I tried to keep myself within 20 minutes, Dr. Misko. So it feels a lot shorter, and I'm happy to answer any questions and hang out for however long. I kind of overheard a little bit about the baclofen pump potentially worsening scoliosis, I think was one question.
Yeah.
I think one of the things that that comes to mind when I think about that is the dystonia at times. When we treat with the baclofen pump, classically, we think about it treating spasticity, and it originally, one of the criteria when you're evaluating patients for a baclofen pump was that you kind of prove that they had spasticity and not necessarily dystonia. We've gone away from that because we found you can treat dystonia with baclofen pumps, but they often need significantly higher doses. So if you are potentially have a baclofen pump and the dose is on the lower side, whether it's due to constipation or not seeing necessarily an effect, it may be that you would benefit from an increased dose. And sometimes that's a fairly significant dose, a pretty high dose to get into treating the dystonia. But if you're getting tightness and kind of contorting from that, that may be affecting the scoliosis. But again, it's hard to say 100%.
Thank you so much, Brian. There's so many questions. And as you know, part of the challenge, I'm going to have you stop sharing your screen so we can go to gallery, if that's okay with you.
Yep.
Part of the challenge, particularly with the nature of the information that you are sharing, is that every parent on this talk has particular questions for you. Because the information that you're sharing is so specific to every family, and there are a lot of specific questions that people have that I know are very hard for you to answer, kind of individually. So I'm trying to sort of ask the questions here that are a little bit more generalizable, but the information you've shared is so helpful. You were talking about scoliosis, of course, and it's a question that reaches kind of across the age spectrum. There were several parents who had questions around how early would you recommend people begin screening for scoliosis, and with what frequency to do this. There isn't really any kind of standard, I would say, within the community.
No, I think early on, age-wise, of when to start getting films, when we look at the hip literature, often if we're worried about hip dislocations from tone, and I think some of that is similar to when we'd be worried about the tone and the muscle disease and that sort of affecting how our spine is forming. It's often relatively early. I think we usually say sometime around 2 or 3. We recommend getting baseline films to take a look. I have kids that I've done earlier on if I have significant concerns about how they're looking functionally and how they're progressing, if I notice the tone is getting worse, or if there's clinical concern, right? If you're looking at the patient and you feel like there's obvious change in how their spine is forming or there's rib humps. In terms of how frequently, it depends on, I think there's a couple aspects to that. If you have access, so our orthopedic department has kind of our low radiation x-rays that we use, and with those, I think you can be significantly less concerned about getting frequent x-rays. And I think every 6 months is usually a good range of how frequently you can do it.
Mm-hmm.
More than that is probably overkill.
Sure.
If you are using standard x-ray, having a clinical exam every 6 months, if there's concerns about change, you can move forward and get repeat films. If there's not necessarily concern, every year is probably worthwhile. And as they get older, if you find that they're relatively stable, you can either do it clinically or every 2 years or so and moving out from there. But yeah, often how that progression is, when we see kids moving forward and their tone is changing, they're growing more, we will get films more frequently to go through that.
Okay, that's great. That's very helpful. Very, very helpful. I think some people were really interested in hearing more about nighttime bracing and whether, so the knee stabilization is one thing, but whether you would recommend more regular use of AFOs at night for stretch.
Yeah. So nighttime resting AFOs I think are a great option. The big things are really individual tolerance of it, right? So if we're seeing kids that are getting tighter, we can't necessarily get them, or we can just get them to neutral. And stretching has been a challenge, or whatever the other challenges out there. Nighttime resting AFOs can be a great option. There's a lot of different forms of them, from just a solid AFO that you put them at neutral, you get them into that spot, and they hold them there. There's ones with dorsiflexing check straps, which go kind of from the toe up to the shin, and you can pull those tighter as you go. I often like those on some of my patients is in the evenings when they're, if you start a little earlier, when they're sitting up, they're watching TV, you can kind of put a stronger stretch into them. And then when they go to sleep, you can loosen it up a little bit and give them the option of being more comfortable. Because that's often one of the biggest limiting factors of these, is that children just don't tolerate it. And within an hour or 2 hours, sometimes 4, they're off in the middle of the night.
Right.
I always talk to families, if they're able to wear them for a few hours in the evenings, if you think about how much that is versus when we sleep, often our ankle is flopping down. If we're able to keep it at neutral for 4 hours at night, that's a big swing compared to being in plantar flexion for those 4 hours. So even if we're getting them on for a couple hours in the beginning of the night, and then they're coming off sometime in the middle of the night, which is pretty common, especially in our younger kids and that sort, I think that's often okay, and we'll get our benefit. We also talk to families about alternating. So we sometimes will use them on the left foot and then one night, and then switch it over to the right foot the other night if kids can't just tolerate both feet at the same time. So really, you just need to work with the children and families to figure out how they're going to tolerate it.
Right.
The knee immobilizers, just to touch on it, I think are a great option as well if you have a lot of hamstring tightness. When we sleep, we often curl up and our knees are up tight. And again, that swing of being extended for a couple hours versus being flexed and curled up for a couple hours can make a big difference. I will say the knee immobilizers, more than even the AFOs, often need to be alternated, as kids don't necessarily tolerate both of them all night long.
Right. That's a great suggestion, the alternating. Another question what had to do with that great point that you mentioned, that if kids are using their trunk too much when they're seated, they're not going to have as much capacity to use their arms for motor use. Do you have a recommendation, and this could be something you follow with that I can send out, but do you have a best recommendation for a chair or chairs, depending upon age, for kids to use while eating?
I will say I'd have to look through. I have a wonderful kind of senior PT that works for my equipment clinic that I think one of our patients was supposed to see this weekend. I was just talking with her on Friday, but I often see our children in the Rift and activity chairs, even for eating as well. The tomato seat they often recommend for different options with additions, but I can also ask her for some recommendations as well.
Okay, and especially, I know some people use the Rift-In. If there's one that can allow children to be at the table, that's a nice option too. But
Gotcha.
Just another thought there. We had a question about when we have parents who struggle with Botox. Parents do obviously have been encouraged, and some parents have success with Botox. When you see a lack of success with Botox, is there another first or second line strategy that you tend to employ for that same need?
Yeah, so I think that, the question of focal tone management versus oral tone management, or, surgical is often a good discussion. Botox, I think, is a great option. Often we do run into issues in terms of dosing where we may not be able to have enough, particularly in the little kids. If there's a lot of adductor tone or hamstring tone, there is phenol, which is an alcohol that has been used for years and years. It can only be used in a certain muscle groups, which are really the adductors and the hamstrings. What it does is you inject right by the nerve, and it actually takes the insulation, it dissolves that insulation for a period of time. And so you can see effects for up to about 9 months or so, as that kind of regrows and there's resprouting and that sort. So I think that that's an option out there. If you're finding that either one, the Botox, you don't have enough of it to treat all the muscle groups you're really trying to target. If you find that you were having success with the Botox and now it's wearing off, sometimes there can be antibody formation, switching to a different botulinum toxin. So Dysport recently got approved for children. There's MyoBlock, which is a little bit more different. So both Botox and Dysport are on a botulinum toxin A. MyoBlock is on a botulinum toxin B. So switching the type of botulinum toxin that you're using can sometimes be successful. That's often where I start, or potentially trying to go up on the dose for that targeted muscle.
Right. Okay. I'm just looking, I know we're very late on time here, but question about the utility of cannabis oil?
So we have, I have a number of children with other neurologic disorders on it. I think the biggest thing from my standpoint, it was approved in adults for spasticity and tone and seizures. So there's a lot of aspects that I think can be beneficial. The hardest part is what to give children, right? So how much CBD are you supposed to be giving? There's really not a lot of clarification on that. We don't have good research on it. Should there be THC in it? Should it just be CBD? What the combination and balance between those two, is that really what's making it beneficial?
Yeah.
I've definitely seen patients that have had benefit from it and swear by it. I just think the biggest thing from my standpoint is knowing that it's not without risk and using it in a stepwise manner, and then trying to do it in the most kind of controlled manner as well. So you know
Correct.
how much CBD you're giving, which one you're using, and being consistent about it. Particularly if there's seizures involved as well, you know, all of them interplay, and making big changes can cause effects from it.
Sure. I think we've come to some of the questions. If there are additional questions, of course, for any of the presenters today, you all know how to reach me, and I'm happy to forward those continued questions to them. I see this as a extraordinary experience today. Obviously, the length of time that we've had to have this conversation is witness to that, and it really is going to be an ongoing conversation. I want to highlight two particular things about it. Not only that this is really really in some ways the beginning of the conversation, as I said, this is the launching point for all the work that is going to come after this, which depends really upon all of you here for your questions and your interest and your activity and your energy. And to that point, I want to say that I think it's pretty clear from what you've heard today that we can only continue to succeed and do the work based on really two things. One of them is your participation in the research. And so if anybody here has not taken steps to reach out and consent to the Natural History Project that Dr. Misko spoke so eloquently and deeply about, we really would love to hear from you. If you have past records, if you have ongoing medical participation, we really want to know how you can share those records with us. They are held in a very secure fashion. Your child is de-identified. No one will know your child's name and address and all that identifying information, and you can learn more about it by contacting me. But you would be making an incredible contribution to the research that you learned about today by sharing those records, and all you have to do is email me. And the other thing is that none of this is free. And Randy Gold has done more than a hero's work in creating the funding and research support for this project with me. But we need everyone's participation to go forward and make it happen, to support the work that Dr. Wishart, that Dr. Misko, that Dr. Grishuk does. And we really enjoin and ask for your participation in making that happen. There is no effort too small, and there is no need too big. And I'd like to just then turn the final comments as I end by thanking Beyond Measure the presenters today, Albert, Brian, Julia, and again, Sue, for the work they do. These people could work on absolutely anything. That is how talented and gifted they are. And the work they do for your kids actually brings me to tears right now. So I thank them from the bottom of my heart. And I just turn now for some closing remarks to Randy before we conclude. And you will be all getting a copy of this recording shortly once it's finalized. Randy Gold?
So Rebecca was moved to tears because she loves every single one of our children as if they are her own. And there's no way that we could appropriately thank you, Rebecca, for everything that you are doing on behalf of our kids, as I see you wiping tears away. I'm the crier in my family, so if you know me, you know that if Rebecca keeps this up, I will also cry. But Rebecca, really, we all just want to thank you again for everything that you're doing for our kids. Also, Julia and Sue and Albert, you know how much I love each one of you individually. Dr. Wishart, when we have a chance to meet, I'm sure I'll love you too. But everyone on this call who has a kid with ML4 recognizes that you have dedicated your lives to really improving the lives of our kids. And so from the bottom of our hearts and beyond, we thank all of you too for the work that you're doing. So thank you very, very much for everything. And, you know, one point that I want to make here, we heard so much from Dr. Misko and Dr. Wishart that was practical in our everyday care for our children. And so we heard from Julia, Dr. Grishuk at the very beginning about the progress that's being made in research. And much of it, because we are not researchers ourselves, we certainly don't have the same comprehension. What I want to point out here is if you have been to an ML4 conference in the past, what you heard was an experiment that might be something that could help ML4, or you heard some theories, or you heard some data. What you heard here today is called progress. And it is actually something that has real opportunity to benefit our kids. This is not theoretical. This is real. And unfortunately, we couldn't see the videos that Julia wanted to share. I don't know if she can share them outside of this forum because I know that they are protected information. But I will tell you that the work Julia is doing is really the thing that we are all counting on to make an important difference for our children. So the difference between what you heard today and what you've heard in the past is that this will lead us, God willing, to a treatment. Yes, it'll take a little while, but that time frame is being shortened as Julia does her work and as science progresses. And frankly, as we generate enough funding to keep this timeline short. The more we can fund the research, the more quickly we can get to a treatment for our kids. So I welcome all of you to reach out to Rebecca, to reach out to me. If you know me, you know I'm one of like the 3 people on the planet who's not on Facebook. But my wife Caroline is, and Rebecca knows certainly how to get in touch with me. So if you want to do anything to help in the fundraising efforts, I'd be glad to hear from you. Thank you all so much for joining us today. Stay healthy, stay safe, and keep continued prayers for all of our researchers' success in your minds. I look forward to seeing all of you very soon in person. Take care, everybody.
Bye, love you all. Stay safe. Let's talk soon.
Thank you so much.
Thank you. It was phenomenal.
Amazing.
Hi, Sophie.
Hi, Steve.
Oh,
Thank you very much, Rebecca.
Thanks, Monica. Hey, Tommy. Sophie.
You said, hi. You always rock. You always rock. You are my superhero. Thank you.
Hey, Monica, it's so good to see you. Sophie, you look so grown up with your hair in a bun.
You see?
Sasha,
I'm
what time
blonde.
is it?
No, I don't know.
Sandy and
Yep.
Sasha, what time is it?
It's 20 in the afternoon.
Me?
What time?
3:30 a.m.
Oh my gosh, when I saw you both there, I just about lost my mind. You're amazing.
Hello!
It's a one-off.
You guys are so amazing.
Go back to sleep, Australia.
I'm doing. Thank you so much, guys. This was absolutely remarkable, and I'm a bit overwhelmed, and I have to go, but all the very best.
Go to bed. You guys are amazing. Love you.
Wow.
Hey, Suzanne.
Say bye.
Thank you so much.
Hey,
Danielle.
Hassan.
Is Nye there? Wasim, is Nay there? No, I think she just. Hey.
Say hi. Say hi. Give a kiss.
Oh, hello.
Give a kiss.
sweetie.
Give a kiss. Mwah.
Rebecca, how soon do you think we can have the video?
Say hi. Oh, say hi.
Hi, Munchkin.
Oh, Jonah.
Give a kiss. Give a kiss. Give a kiss.
Danielle, did I get a big smile?
Rebecca?
Yes, Monica.
Hello,
Oh, wait a sec. I'm getting my big smile from Danielle. I can't handle myself.
Melissa.
Danielle, I wait. I
Oh,
wait.
Danielle, you're so cute. I love you, honey.
He loves listening to Rebecca. Say hi.
Say hi, Rebecca.
Give her a big wave. There, Rebecca.
Hey, honey. Hello, Alyssa. Hello, sweetie. Hi, Danielle.
Danielle.
Yeah.
Oh, how are you, girl? Are you going outside today? How's the weather? Is it warm up?
I don't know. We haven't been out today.
Oh, Danielle wants to go out and see all of her friends. I've seen some good pictures of you outside, cutie.
Can't wait for the mall to reopen.
Oh, please. Her and Rachel, they're desperate to meet up at the mall.
Rebecca, when do
Yeah.
you think we can have, when do you think we can have the audio?
I have to wait for it to process, and then I'll send it as soon as I can. It has to, like, Zoom has to do its little magic.
Okay, thank you very much. I love you. I have to go.
I love you too. I have a meeting also, but oh, Jack! I have to stay and see everybody who will stay and say hi to me. Jack, I haven't seen you in so long, except on Instagram. You're like my little Instagram superstar. You're very chic and black and white often on there.
It's Mike and Annette. We want to say hi. Great seeing everybody.
Oh my gosh, I saw you guys earlier. Hey! So love that you joined. I'm inspired by you for joining.
Nice getting an update and hearing what everything's happening.
Amazing to see you guys.
Sanırım onların çocuğu.
Queens, we miss you. Hope all is well.
We're loving Colorado.
Hi, Tommy.
It looks like it's loving you too, Weens. I follow you in all of your exploits.